Welcome, everyone, to the deep dive. Today, we're plunging into, well, the profound complexity and just incredible resilience of the human nervous
It
system.
really is amazing.
Think about it. This intricate network, from the brain right down to the tip of your toes, it orchestrates literally everything we think, feel, and do. It's a true marvel.
Absolutely. Biological engineering at its finest.
But what happens when this delicate yet powerful system faces significant challenges? When it requires maybe the most precise and high-stakes medical intervention you can imagine.
Yeah,
Okay, let's unpack this.
indeed. Our deep dive today is really an exploration of various neurosurgical conditions.
All right.
We're going to journey from intricate brain tumors and serious vascular diseases,
Mm-hmm.
the things that threaten the brain's very blood supply,
Great.
all the way down to the often debilitating chronic spinal pain that impacts millions.
So common.
It is. And along the way, we'll uncover the advanced diagnostic and treatment strategies that modern medicine is employing. Our goal for you, the listener, is really to extract those critical insights. Maybe demystify these conditions a bit
Yeah, break it down.
and really highlight the ingenuity and precision that defines contemporary neurosurgery. Think of this as maybe your shortcut to being genuinely well-informed
Mm-hmm.
about a field that touches countless lives, all without feeling, overwhelmed by just the sheer volume of information.
And as our expert guide through this fascinating and, let's face it, sometimes incredibly intricate landscape, we're drawing from a comprehensive ebook.
That's right.
It's packed with essential factual insights that will lay the groundwork for understanding this vital field, giving us the perfect launching pad for our conversation today.
Our mission isn't just to sort of lay out facts, but to help you connect the dots, understand the why behind these conditions and treatments.
Right,
And perhaps even uncover some truly surprising facts you might not have known.
Yeah.
We want to foster a deeper understanding that hopefully resonates long after our conversation concludes.
Okay, let's get started then. Let's start our journey right at the top with the brain. It's, well, a symphony of precision, yet also incredibly vulnerable.
It really is a paradox.
And one of the most serious challenges it can face are brain tumors. Now, these are often described simply as, abnormal growths. But can you clarify what makes them so distinct, especially in the context of being inside the brain?
Absolutely. When we talk about brain tumors, it's crucial to understand their distinct nature from other cancers you might find elsewhere in the body.
Okay.
A primary brain tumor, for instance, originates directly in the brain.
Oh.
What's interesting about these is they generally don't spread to other parts of the body.
Ah, okay, so they stay put.
They tend to, yes.
Yeah.
They tend to grow relatively slowly and often have defined, distinct boundaries. Their cells, while abnormal, aren't always classified as malignant in quite the same way typical cancer cells are. Now, contrast that with a malignant brain tumor. These grow quickly, they have irregular boundaries, and unfortunately, they can spread to nearby brain areas.
Uh-huh.
While we often call them brain cancer, they typically don't metastasize beyond the central nervous system itself.
I see.
Then you have metastatic or secondary brain tumors. These are quite different because they actually originate somewhere else in the body cancer cells from, say, the lung or breast.
Oh,
They
right.
get carried by the bloodstream and spread to the brain. In fact, lung and breast cancers are the most common primary sources for these metastatic brain tumors.
So they're not brain cancer that started there, but cancer that, well, found its way to the brain.
Precisely.
Oh,
An
yeah.
invader, essentially.
So whether it's a primary, malignant, or metastatic tumor, they're all growing inside the skull, which is, a rigid, fixed space. That sounds like a critical challenge right from the start, a really unique problem compared to a tumor in, say, an organ that can expand a bit.
You've hit on the most critical consequence, and it's something often overlooked. Imagine a growing mass within a perfectly sealed, unyielding container.
Yeah.
The brain is enclosed within this rigid, bony skull, and it has absolutely no room to expand and accommodate any new mass.
Not at all.
The profound result is that as a tumor grows, it displaces and compresses normal, healthy brain tissue, which can be absolutely devastating.
Wow.
Furthermore, some brain tumors cause significant swelling or edema around them, which only exacerbates this pressure problem.
Right, adding even more volume.
Exactly. This is precisely why all malignant or metastatic brain tumors are considered potentially life-threatening, regardless of their initial size or inherent malignancy.
Hmm.
The confined space makes even a relatively small, fast-growing tumor extremely dangerous, as it can quickly push on vital brain centers. There's just nowhere for the pressure to go.
That rigidity really underlines the delicate balance at play, doesn't it?
It really does.
What about the variety of these tumors? Are there many different types or just a few main ones?
Oh, there are quite a few, and their classification is very important for diagnosis
Hmm.
and for treatment planning. We have broad categories like gliomas, which is really an umbrella term encompassing many different forms and grades.
Okay.
Some, like certain astrocytomas, can be quite slow-growing, while others, like glioblastoma, multiform GBM, are notoriously aggressive.
Right, I've heard of that one.
Yes. Beyond gliomas, we also see others like craniopharyngioma, lymphoma, meningioma, schwannoma, and pituitary adenoma, just to name a few. There are many others.
Wow, quite a list.
It is. And this diversity in their cellular origins dictates how each tumor behaves and, importantly, how we approach its treatment. It makes precise diagnosis absolutely crucial.
With such a wide range of types, what do we actually know about their causes? Can we prevent primary brain tumors? Is there anything you can do?
That's the million-dollar question, really. For primary brain tumors,
Mm-hmm.
those that start directly in the brain, medical science, unfortunately, still doesn't definitively know how to prevent them or precisely what causes them in most cases.
Mm.
However, we have identified some known risk factors. These include having an existing cancer elsewhere in the body.
Right, the metastatic ones.
Exactly, which can lead to those secondary brain tumors.
Mm.
Also, long-term contact with certain chemicals, such as pesticides, industrial solvents, and other specific chemicals, has been identified as a risk factor.
Interesting.
And additionally, some inherited diseases like neurofibromatosis are known to increase a person's susceptibility to developing brain tumors.
Okay.
So while we can't really prevent them yet in the broad sense, understanding these risk factors helps in managing potential predispositions or identifying high-risk groups.
So prevention isn't fully understood, but symptoms, I imagine, are key for early detection. How do they manifest? And does the tumor's location within the brain really influence what someone experiences that much?
Oh, absolutely. The symptoms are, in fact, heavily dependent on the tumor's type, its size, and crucially, its precise location within the brain. Generally speaking, common symptoms that might indicate a brain tumor include headaches, which often tend to worsen in the morning. It's a bit of a classic sign.
Mm-hmm.
Seizures, dizziness, difficulty walking, or maybe a tendency to stumble. People might also experience speech problems, vision problems, or weakness just on one side of the body.
Okay, those sound like fairly general neurological signs.
Yes, they can be. But a critical general symptom as a tumor grows and pressures the brain is increased intracranial pressure.
Ah, that pressure cooker effect again.
Exactly. And that manifests as drowsiness, those characteristic headaches we mentioned, nausea and vomiting, and just sort of sluggish responses.
Right.
But what's particularly fascinating and really highlights the brain specialization is how the tumor's location dictates very specific symptoms.
So, okay, give us some examples.
Right. So if a tumor is in the frontal lobe, which is responsible for personality, judgment, higher cognitive functions,
The executive center.
pretty much, you might see behavioral and emotional changes, impaired judgment, maybe a loss of the sense of smell, memory loss, or even one-sided paralysis.
Wow.
A tumor in the parietal lobe, which is involved in sensory processing and spatial awareness, could lead to a lack of recognition, inability to write, or spatial disorientation.
Mm.
If in the occipital lobe, back here,
Hmm.
which processes visual information,
Vision, right.
the primary symptom would likely be vision loss in one or both eyes. The temporal lobe, critical for speech and memory, would likely present with impaired speech and memory difficulty.
Okay.
And finally, a tumor affecting the brainstem, which controls vital functions like breathing and heart rate and connects the brain to the spinal cord.
Super critical area.
Extremely.
Yeah.
That could cause a wide array of symptoms from difficulty speaking and swallowing, drowsiness, hearing loss, muscle weakness on one side of the face or body, even a drooping eyelid or double vision.
It's incredible. The brain's precision means even subtle pressure in a specific spot can have these profound and really localized effects.
Exactly. It maps function very clearly.
That's a truly detailed picture. Given that variety of symptoms and locations, how do doctors even begin to diagnose these complex conditions? What's the process?
The diagnostic journey is Comprehensive and quite methodical. It usually begins with the doctor meticulously collecting the patient's personal and family medical history.
Looking for clues.
Exactly. Seeking clues about predispositions or previous conditions. This is followed by a complete physical examination. And crucially, a detailed neurological exam is performed.
Okay, what does that involve?
That assesses various neurological functions.
Hmm.
Mental status and memory, vision, hearing, smell, tongue and facial movement, muscle strength, coordination, reflexes, and the patient's response to pain. This gives a broad overview of neurological integrity, trying to pinpoint any deficits.
Right, mapping out any problems.
Precisely. To get deeper, sometimes a lumbar puncture, also known as a spinal tap, might be performed.
Ah, okay.
This involves carefully collecting a small sample of cerebrospinal fluid, that's the fluid surrounding the brain and spinal cord, and examining it for any signs of tumor cells, abnormal protein levels, maybe infection, or blood.
So looking for cellular clues.
Yes. And then, imaging techniques are paramount, absolutely essential.
Like CT scans and MRIs.
Exactly. A computed tomography, CT scan, is a non-invasive test that uses an X-ray beam to create two-dimensional images or slices of the brain. It offers a quick overview, often a first step.
Okay.
A magnetic resonance imaging, MRI scan, on the other hand, provides even more detailed views. It shows the brain in slices, layer by layer, using magnetic fields and radio waves. The soft tissue contrast is incredible.
Better detail.
Much better for soft tissues. Often, a contrast dye is injected into the bloodstream before an MRI. This helps to highlight specific structures or abnormalities more clearly, making tumors sort of light up distinctly against the background brain tissue.
So imaging gives us a great visual, a picture inside the head. But what if the scans aren't definitive? What if there's still uncertainty? Is there a way to get a direct look at the tumor cells themselves for a really precise diagnosis?
Yes, absolutely. In cases where the diagnosis isn't crystal clear from the scans alone, a biopsy is often performed. This is really the definitive procedure to determine the exact type of tumor, which is absolutely crucial for guiding the right treatment.
Makes sense. How's it done?
It involves surgically removing a small amount of the tumor tissue. This tissue is then meticulously examined by a pathologist under a microscope.
Oh, okay.
A common method for this is a needle biopsy. In this technique, a small hole is drilled in the skull, and a hollow needle is carefully guided, often using imaging like CT or MRI for guidance stereotactically.
Right, pinpoint accuracy.
Exactly into the tumor to extract a tissue sample. It's important to note, though, that a biopsy can be a more complex procedure, especially for tumors located deep within the brain or in really critical sensitive areas. The precision required is immense.
I can only imagine. Okay, so once a diagnosis is confirmed, perhaps through a biopsy, what are the primary treatment approaches for brain tumors? What tools do neurosurgeons have?
Well, there are three main pillars of treatment for brain tumors: surgery, radiation therapy, and chemotherapy.
The big three.
The big three. And often these are used in combination, forming a multifaceted approach that's tailored to the specific tumor type, its size, and its location.
Okay, let's break this down. Surgery first.
Let's start with surgery, specifically a procedure called craniotomy. This is where a neurosurgeon, a specialist in brain tumors, carefully opens the skull to directly access and remove the tumor.
Right.
The aims of brain surgery are actually multifaceted. It can be to definitively diagnose the tumor type, like we just discussed with biopsy. It could be to remove the entire tumor in hopes of a cure, if that's possible.
The ideal scenario.
The ideal, yes, but not always feasible. Perhaps more commonly, the goal is to remove as much of the tumor safely possible. This partial removal, or debulking, aims to slow its growth, alleviate symptoms by reducing that dangerous pressure,
Ah, okay.
and also make other treatments, like radiation or chemo, potentially more effective.
I see. Does surgery have other roles too?
It can. Surgery can also facilitate other treatments. For example, surgeons might insert chemotherapy wafers directly into the tumor site after removal.
Oh, targeted delivery.
Very targeted. Additionally, surgery might involve placing a tube, called a shunt, to drain excess cerebrospinal fluid from the brain and relieve dangerous pressure. Or inserting a small plastic capsule, like an Ommaya reservoir, under the scalp.
What's that for?
That allows for direct, targeted injection of cancer drugs into the cerebrospinal fluid over time, bypassing the blood-brain barrier.
Clever. Okay, what about radiation? How does that work?
Radiation therapy uses high-energy rays to treat brain tumors. These rays can be delivered either externally from a machine outside the body targeting the tumor, or internally, where radioactive material is placed very close to or even inside the tumor.
Okay. And the goal?
The fundamental mechanism is that this radiation damages the DNA inside the tumor cells. This damage makes them unable to divide and reproduce, so the tumor hopefully shrinks or stops growing.
Right.
The primary aim is always a delicate balance. You want to maximize the radiation dose delivered to the abnormal cells while rigorously minimizing exposure to the surrounding healthy, normal brain tissue. That's critical.
Precision again.
Always precision. The benefits of radiation therapy aren't immediate, usually. They tend to accumulate over time. And interestingly, aggressively growing tumors, whose cells divide rapidly, typically show a quicker response to radiation.
Okay. And the third pillar, chemotherapy.
Finally, yes, we have chemotherapy. These are drugs that work by disrupting the process of cell division.
Okay.
Because they specifically target rapidly dividing cells, they unfortunately impact not only the tumor cells, but also other fast-growing normal cells in the body. Think about cells in hair follicles, the digestive system lining, and blood cells.
Right, which explains the common side effects.
Exactly. This is why chemotherapy is commonly associated with side effects like hair loss, nausea, fatigue, and reduced blood counts.
When is chemo typically used for brain tumors?
It's used in several scenarios, sometimes after surgery for certain types of brain tumors to try and prevent recurrence, often in conjunction with radiotherapy, and sometimes continued for several months afterward to increase survival rates, particularly for aggressive tumors. Or it might be used to treat a brain tumor that has recurred after initial treatment.
And how are these drugs given?
They can be administered in various ways, sometimes as an oral pill, often intravenously through an IV drip, or, as we mentioned earlier with surgery, sometimes as a wafer that's surgically placed directly into the cavity where the tumor was removed.
Right, that targeted approach again.
Yes. Common chemotherapy drugs used specifically for brain tumors include agents like carmustine, lomustine, and temozolomide.
That's a powerful trio of treatments: surgery, radiation, chemo, offering different avenues of attack. But as you mentioned earlier, medicine is constantly evolving. What are some of those truly revolutionary, maybe less invasive treatments making a difference today, especially for brain tumors? You hear things like the Gamma knife. What's that about?
That's a great question because the Gamma knife really represents the significant leap forward into, well, precision and promise.
Okay.
Gamma knife therapy is a prime example of a highly precise, powerful, and proven treatment, particularly for brain tumors, skull-based tumors, and other brain disorders. The crucial point here, the real game changer, is that it does not involve traditional open surgery.
No scalpel.
No scalpel, no incision. Instead, it works by focusing 201 precise beams of radiation directly onto the tumor.
201. Wow.
Yes, 201 individual beams. Individually, each of these beams is actually too weak to cause significant damage to the healthy brain tissue it passes through on its way to the target.
Ah, I see.
But where all 201 beams converge at the exact location of the tumor, their combined energy delivers a very potent, precisely sculpted, customized radiation dose just to the abnormal tissue.
Incredible convergence.
It is. And before the treatment, detailed imaging, typically high-resolution MRI, sometimes CT or angiography, is used to establish the exact three-dimensional target for the radiation and determine the precise amount needed, down to fractions of a millimeter.
That sounds incredibly precise, as you said. What are the specific benefits for patients receiving this type of therapy, especially when you compare it to traditional open surgery?
The benefits are really significant, which is why it's become such an important tool. First, as we've emphasized, there's unparalleled precision. Because the radiation dose is customized and focused so acutely, it targets only the diseased tissue, remarkably sparing the surrounding healthy brain tissue. This minimizes side effects.
Makes sense.
Second, it offers incredible safety. Patients usually only require local anesthesia, not general anesthesia. And because there are no incisions, it eliminates the risks typically associated with traditional open skull surgery.
Like infection.
Exactly. Risks like infection, bleeding, cerebrospinal fluid leaks, and other complications that can come from exposing the brain.
Right.
Third, it's remarkably effective. Generally, only one treatment session is required for many conditions. And it is proven effective even for treating cancers that have spread from other areas of the body to the brain, those metastatic tumors we talked about.
One session, often. That's efficient.
It can be, yes. And finally, it's technologically advanced. The delivery of the radiation is robotically controlled, which allows surgeons and radiation oncologists to deliver the radiation with even greater precision, safety, and speed than ever before. It truly represents a leap forward in neurosurgical treatment without a scalpel.
It's just amazing to think about targeted treatment without an actual incision. Now, what about using the body's own immune system? We hear a lot about immunotherapy and cancer treatment generally. Is it playing a role yet in fighting these aggressive brain cancers?
Yes, immunotherapies are very much at the forefront of the future for brain tumors, and there are some really promising developments happening right now in targeting brain cancers.
Okay, like what?
Well, one example is DCVax-L. This is a type of dendritic cell immunotherapy, which basically uses the patient's own immune cells, trains them outside the body to recognize the tumor, and then puts them back into fight. It's currently in a phase 3 trial for newly diagnosed glioma, which includes things like glioblastoma and astrocytoma.
Training your own immune system. Fascinating.
It is. Another exciting development is rindopepimut, or CBX-110. This is actually a therapeutic vaccine. It targets a specific peptide, a protein fragment called EGFRV8, which is expressed on the surface of cancer cells in a significant percentage, maybe 24% to 67% of glioblastoma patients.
So a targeted vaccine against the cancer.
Essentially, yes. Rindopepimut is being tested in several ongoing trials. A phase 3 trial for newly diagnosed glioblastoma, a phase 2 trial for patients whose EGFRV positive glioblastoma has relapsed or come back,
Mm-hmm.
and even a phase I trial for children suffering from a particularly difficult tumor called diffuse trinsic pontine glioma, or DIPG, after they've had conventional radiation.
That's hopeful, especially for pediatric cancers. Any others?
Yes, there's also ICT-107. This is another immunotherapy approach currently in a phase 2 trial for patients with glioblastoma multiforme. Early results from a previous phase of this trial actually showed very promising improvements in survival for a small group of treated patients, so there's a lot of hope riding on these ongoing studies.
Those immunotherapies sound incredibly promising, especially as you said, given the challenging nature of some brain cancers. Can you give us some crucial context on just how aggressive certain brain cancers truly are? Because these new treatments matter so much in that light, don't they?
Absolutely. What's truly vital here, and often not fully appreciated maybe outside the medical community, is the stark reality of glioblastoma multiforme, or GBM.
Right.
This is undeniably a very dangerous and aggressive form of brain cancer, and its statistics really underscore why these advancements are so desperately needed.
Okay.
Patients diagnosed with GBM typically face very short life expectancies. It's a sobering fact that only a small percentage, specifically around 26.5%, of newly diagnosed GBM patients live beyond 24 months, or 2 years.
Wow, only about a quarter.
Yes. And a mere 16% survive for more than 3 years.
That's incredibly tough.
It is. With the current standard of care for newly diagnosed GBM patients, which usually involves surgery, radiation, and chemotherapy with temozolomide, the median progression-free survival, meaning the typical time until the disease starts to worsen again, is just 6.9 months.
Less than 7 months.
Yes. And the median overall survival is only 14.6 months.
About a year and a quarter.
That's right. These grim realities are precisely why these innovative targeted therapies like Gamma Knife and the immunotherapies we're discussing aren't just incremental advancements. They represent new frontiers of hope for conditions where hope was once desperately scarce. The goal is absolutely to extend and improve quality of life.
That really drives home the critical need for these innovative approaches and why every single month gained is so incredibly precious for these patients and their families.
Absolutely critical.
Now let's shift our focus a bit. We've talked about growth inside the brain, but let's turn to another vital aspect of brain health. It's blood supply. What happens when those crucial pipelines, like the carotid arteries in the neck, start to fail? Specifically, let's talk about carotid artery disease.
Right. If we connect this to the bigger picture, the brain's complete reliance on a steady, robust blood supply makes any condition affecting its arteries incredibly serious.
Makes sense.
Carotid artery disease is precisely that. It's defined medically as carotid stenosis, which simply means a narrowing of the carotid arteries. And this narrowing is caused by the buildup of plaque inside the artery walls.
Plaque, like you hear about in heart disease.
Exactly the same stuff, atherosclerosis. You have two major carotid arteries, one on each side of your neck. They are the primary conduits carrying oxygen-rich blood directly from your heart up to your brain.
The main highways.
The main highways, yes. So any narrowing here, any bottleneck, is a serious risk factor for stroke and can lead to permanent brain damage because it restricts that vital blood flow.
Okay, so how does that plaque actually build up? What's the process?
The process behind this is called atherosclerosis. As we age, or due to factors like high blood pressure, smoking, high cholesterol, diabetes, small injuries can occur to the inner walls of these blood vessels. These injuries allow a sticky substance, the plaque, which is made up of fat, cholesterol, calcium, and other fibrous material, to start building up inside the inner wall of the artery. This plaque forms a mass, sometimes called an atheroma, that narrows the lumen.
The lumen.
That's the inner diameter, the open channel of the artery. And this buildup reduces blood flow to the brain. Healthy arteries are flexible with smooth inner walls, so this plaque buildup is a significant departure from normal function and poses a direct threat to brain health.
That sounds like a silent threat, building up over time. Do people even know they have it before something serious happens, or is it often, too late?
Often they don't. And that's what's truly insidious about carotid stenosis. It frequently has no symptoms at all until the artery becomes severely narrowed, or even worse, a blood clot forms on that rough plaque surface and then travels up to the brain, causing a blockage.
Ah, so the first sign could be a stroke.
It could be.
Huh?
Or often the first symptoms appear as a mini-stroke, medically known as a transient ischemic attack, or TIA.
TIA.
Right. TIAs are characterized by a temporary interruption of blood flow to the brain. The symptoms are stroke-like, maybe weakness, numbness, speech difficulty, vision loss. But they typically last only a couple of minutes, maybe up to an hour, before resolving completely with the person returning to normal.
So they go away completely.
They do. But, and this is absolutely crucial, TIAs are not to be ignored. They are definitive warning signs, like warning shots.
Okay.
They indicate a very high risk of a looming major ischemic stroke and potential permanent brain injury. Symptoms of a TIA or an ischemic stroke can include that sudden weakness or numbness, usually on one side, in an arm or leg, difficulty speaking or understanding speech, a drooping face, a temporary loss of sight in one eye, sometimes described as a curtain coming down,
Oh, wow.
ringing in the ears, which is called tinnitus, or even paralysis affecting one side of the body. If you or someone you know experiences any of these, even if they go away quickly, it's an immediate medical emergency. 911.
Absolutely critical message. So if someone experiences a TIA, that's a clear signal to investigate the carotids. How do doctors diagnose carotid artery disease then? And what clues are they listening for, you mentioned?
Diagnosis involves a combination of a thorough examination and advanced imaging. The doctor will start by taking a comprehensive history, asking about your symptoms, current and previous medical problems, medications you're taking, and family history of stroke or heart disease.
Get in the background.
Exactly. During the physical exam, one of the first things they may do is use a stethoscope to listen carefully to the carotid artery in your neck. They're listening for a distinctive bruit. That's B-R-U-I-T.
A bruise.
Yes, it's a sort of swishing or whooshing noise that indicates turbulent blood flow, which is a classic sign of atherosclerosis, that plaque buildup causing roughness and narrowing.
Like water rushing past a rock.
Exactly like that. If symptoms have occurred or a bruit is detected, you would typically be referred to a specialist, often a vascular surgeon or neurosurgeon, for further evaluation and potentially surgical consultation.
Okay, and what about imaging?
In terms of imaging, a color Doppler ultrasound scan of the carotid arteries in the neck is a very common initial diagnostic tool. It's non-invasive, uses sound waves, and can show blood flow, measure its speed, and visualize blockages or narrowing.
Right.
Other methods include a computed tomography angiogram, CPA of the neck, which uses X-rays combined with an injected contrast dye to create detailed pictures of the blood vessels. A magnetic resonance angiography, MRA, uses magnetic fields, again often with contrast, for detailed vessel imaging without radiation. Or, in some cases, a more invasive cerebral angiogram might be performed, which involves threading a catheter up to the arteries and injecting dye directly for X-ray movies.
So lots of ways to get a clear picture.
Yes, these imaging techniques provide detailed views of the arteries and the extent of plaque buildup, helping to precisely locate and quantify the narrowing, which is essential for planning treatment.
Once it's diagnosed and say it's significantly narrowed, what's the surgical approach to preventing a stroke in these cases? It sounds like you need to clear those arteries out somehow.
Precisely. The general goal of surgery for carotid artery disease is, fundamentally, to prevent a potentially devastating stroke. This is done by reducing or removing the plaque buildup and expanding the artery's lumen, that inner diameter, to allow more blood flow to the brain.
Okay.
Surgeries are typically recommended for patients who have already experienced one or more TIAs or minor strokes, indicating a high risk of future, more severe events. It might also be recommended for some patients who haven't had symptoms yet, but have a very severe narrowing over a certain percentage discovered on imaging.
Right. proactive prevention, what are the main procedures?
There are a few key surgical procedures. The first, and perhaps the most traditional, is carotid endarterectomy.
Endarterectomy, yeah.
This is an open surgical procedure to physically remove the plaque. The surgeon makes a skin incision in the neck, carefully locates the affected carotid artery, and temporarily places clamps above and below the area of narrowing to stop blood flow through that section.
And the brain gets blood from the other side.
Yes. During this time, the carotid artery on the other side of the neck, or sometimes a temporary plastic tube called a shunt placed within the artery, ensures blood continues to flow to the brain. It's carefully monitored.
Okay.
The surgeon then makes an incision directly into the artery wall over the blocked area, meticulously peels out the plaque buildup, literally scrapes it out and removes it. The artery wall is then closed with tiny sutures, and the clamps are removed, restoring normal blood flow through the cleaned-out artery.
It's a very direct intervention, almost like plumbing.
It is,
Yeah.
in a way, a very delicate form of plumbing.
That's a direct, almost mechanical approach, literally cleaning out the artery. Are there less invasive options available for clearing these blockages, maybe going inside the vessel?
Yes, there is. There's carotid angioplasty and stenting. This is a minimally invasive endovascular procedure, meaning it's done from inside the blood vessel.
Okay, how does that work?
It's usually performed in an interventional radiology suite or a catheterization lab. A flexible catheter is inserted, typically into the femoral artery in the groin, and threaded carefully through the body's arterial system, past the heart, and guided up to the site of the plaque within the carotid artery in the neck, all using X-ray guidance.
Wow, quite a journey.
It is. A smaller catheter with a tiny inflatable balloon at its tip is then positioned precisely across the plaque blockage. When the balloon is inflated, it dilates the narrowed artery and compresses the plaque against the arterial wall, squashing it flat.
Pushing it out of the way.
Exactly. The balloon is then deflated and removed. But critically, to keep the artery open, a self-expanding mesh-like tube called a stent is then deployed across the area where the plaque was compressed.
A stent, like in the heart.
Precisely the same principle. This stent acts like a scaffold, holding the artery open, maintaining that wider lumen, and preventing the artery from collapsing or narrowing down again. This offers a less invasive alternative for many patients, especially those who might be higher risk for open surgery.
Okay, so endarterectomy or stenting. Are there other options, maybe for really tough cases?
Yes, for more complex situations, or perhaps when an artery is completely blocked or occluded, and neither endarterectomy nor stenting is feasible, there's carotid artery bypass.
A bypass, okay.
This is a surgical procedure specifically designed to manage blood supply around a completely blocked carotid artery. In this procedure, a length of artery or vein is harvested from another part of the patient's body, typically the saphenous vein from the leg, or sometimes the ulnar or radial arteries from the arm.
Using your own tissue.
Yes, creating a graft. This harvested vessel graft is then connected surgically above and below the blockage in the neck. It effectively reroutes blood flow through the graft, completely bypassing the occluded section of the original carotid artery.
Creating a detour.
Exactly. This provides an alternative pathway for blood to reach the brain, ensuring it gets the oxygen it desperately needs when the main highway is permanently closed.
It's truly incredible how surgeons can reroute and repair these vital pathways to keep the brain nourished. But what happens when the problem isn't a narrowing or a blockage, but rather an actual bleed within the brain tissue itself? Let's talk about intracerebral hemorrhage, or ICH.
Right. Intracerebral hemorrhage, or ICH, occurs when a blood vessel ruptures and bleeds directly into the tissue deep within the brain. Not on the surface, but within the substance of the brain.
Okay, how common is that?
It accounts for about 13% of all stroke cases, so it's a significant and particularly dangerous form of stroke, often called hemorrhagic stroke.
And what usually causes it?
By far, the most common cause is long-standing high blood pressure, or hypertension. Over time, high pressure can cause the small, thin-walled arteries deep inside the brain to weaken, become brittle, and eventually rupture.
They just can't take the pressure anymore.
Exactly. When blood is released from the ruptured vessel into the brain tissue, it deposits and forms a clot, which we call a hematoma. As this hematoma grows, it acts like a rapidly expanding mass, putting increasing pressure on the surrounding delicate brain tissue, disrupting its function much like a tumor does in that confined space we discussed.
Right, same pressure problem.
Yes. And in severe cases, this deep hemorrhage can even expand into the ventricles, which are the normal fluid-filled spaces located in the center of the brain, causing further complications.
So, uncontrolled high blood pressure is a major culprit. But are there specific types of weakened blood vessels, maybe structural issues, that are particularly prone to this kind of bleeding?
Yes, there are. Beyond the general weakening from hypertension, there are two primary types of weakened blood vessels that are typically responsible for causing hemorrhagic stroke. These are aneurysms.
We'll get to in more detail later.
Yes, those are the balloon-like bulges on arteries and arteriovenous malformations, or AVMs.
AVMs, what are those?
AVMs are tangled messes of abnormal arteries and veins. Critically, they lack the normal capillary network in between. This means high-pressure arterial blood flows directly into weaker low-pressure veins, making the vessels in the AVM inherently fragile and prone to rupture.
So like faulty plumbing from birth?
Often, yes.
Yeah.
These structural weaknesses are inherently more vulnerable to rupture under normal or elevated blood pressure, acting like ticking time bombs within the brain's vascular system.
Scary thought. What would someone experiencing an ICH feel? What are the common symptoms that demand immediate medical attention?
The symptoms of an ICH are typically quite sudden and severe. Common signs include a sudden excruciating headache, often described as the worst headache imaginable,
Mm-hmm.
frequently accompanied by nausea and vomiting due to the increased pressure. The person might experience sudden lethargy or confusion or sudden weakness or numbness, typically affecting one side of the face, arm, or leg.
Similar to ischemic stroke symptoms then.
Yes, the neurological deficits can look similar because brain tissue is being damaged, just by a different mechanism, bleeding instead of blockage.
Yeah.
In more severe cases of ICH, there can be a rapid loss of consciousness, temporary loss of vision, or even seizures as the bleeding irritates the brain tissue. The speed of onset and the severity of these symptoms are critical indicators that something serious is happening.
Beyond hypertension and those specific weakened vessels like aneurysms and AVMs, are there other factors that can trigger an ICH? Perhaps less obvious ones?
Unfortunately, yes, there's a range of other potential causes or contributing factors that can lead to an ICH. As we mentioned, uncontrolled hypertension is the major one, directly leading to ruptured arteries inside the brain.
Right.
Blood thinner therapy, using anticoagulant drugs like warfarin, Coumadin, or antiplatelet drugs like aspirin or clopidogrel, while necessary for other conditions, does increase the risk of bleeding, including in the brain, especially if the levels aren't carefully managed and monitored.
Okay, that makes sense.
Head trauma, such as skull fractures or penetrating wounds from accidents or violence, can directly damage an artery and cause internal bleeding. Certain inherited bleeding disorders, like hemophilia or severe platelet deficiencies like thrombocytopenia, also predispose individuals to hemorrhage because their blood doesn't clot properly.
Right.
Even certain types of brain tumors, particularly highly vascular ones like angiomas or metastatic tumors that have spread to the brain, can sometimes bleed spontaneously into the surrounding brain tissue.
Tumors themselves can bleed.
They can, especially certain types. Another cause, particularly in older adults, is a degenerative artery disease called cerebral amyloid angiopathy, where abnormal proteins build up in the artery walls, making them weak and prone to rupture. And sadly, the use of certain illicit drugs, particularly stimulants like cocaine and methamphetamine, can cause sudden dangerous spikes in blood pressure that can trigger an ICH, even in younger people.
That's a really broad spectrum of potential causes, from chronic conditions to acute events and even drug use. How do doctors confirm an ICH and, if possible, pinpoint the source of the bleeding within the brain's complex network?
Diagnosis relies heavily and immediately on brain imaging. A computed tomography, CT scan of the head, without contrast initially, is usually the very first test done in the emergency room. It's extremely fast and very sensitive at detecting fresh blood, which shows up as bright white on the scan. This confirms the diagnosis of ICH very quickly.
So CT is key for speed.
Absolutely.
Okay.
Once ICH is confirmed, further tests might be done to look for an underlying cause, especially in younger patients or those without a history of hypertension. This might involve a CT angiogram, CTA, where contrast dye is injected to visualize the blood vessels and look for aneurysms or AVMs.
Okay.
An MRI scan and MR angiogram, MRI might also be used. MRI can sometimes provide more detail about the surrounding brain tissue and detect subtle underlying lesions that might have caused the bleed, though it takes longer than CT. In some cases, a more invasive conventional angiogram, also called digital subtraction angiography or DSA, is needed. This is still considered the gold standard for visualizing blood vessels in detail. A catheter is inserted, usually in the groin, threaded up to the brain arteries, and dye is injected while X-ray images are taken. This gives a very clear road map of the vessels and can definitively identify aneurysms, AVMs, or other vascular abnormalities that might have ruptured.
So a range of tools to get the full picture.
Yes, allowing doctors to quickly assess the situation, determine the extent of the bleeding, and plan the necessary interventions.
Once a bleed and ICH is confirmed, what's the surgical strategy for treatment? Is it always about removing the blood clot? What are the goals?
The primary aim of surgical treatment for ICH is indeed twofold. First, to remove as much of the blood clot, the hematoma, as safely possible to relieve the pressure on the surrounding brain.
Right, reduce that mass effect.
Exactly. And second, crucially, to identify and stop the source of the bleeding, if possible, especially if it's from a ruptured aneurysm or AVM. The specific surgical approach chosen heavily depends on the clot size, its location, how deep it is, which part of the brain, and whether there's an underlying structural cause that also needs addressing.
Okay, so what are the options?
For clots that are located closer to the surface of the brain, or if the bleed is associated with an underlying AVM or tumor that also requires removal, a traditional craniotomy is generally performed.
The open approach again.
Yes. This involves the neurosurgeon carefully cutting a precise window or hole in the skull with a drill to expose the brain surface. Under direct visualization, often using a microscope, the surgeon can then gently enter the brain tissue, evacuate the clot, and control any active bleeding points or address the underlying cause, like cleaving an aneurysm or removing an AVM.
Makes sense for surface clots. What about deeper ones?
Right. For large hematomas located deep inside the brain, where an open craniotomy might cause too much damage to the overlying healthy brain tissue just to get there, a less invasive technique called stereotactic aspiration is often preferred.
Stereotactic? That sounds precise.
It is extremely precise. This procedure involves attaching a special guidance frame, a stereotactic frame, to the patient's head, usually using local anesthesia for comfort. A CT or MRI scan is then performed with the frame in place. This allows the computer software to calculate the exact three-dimensional coordinates of the hematoma within the brain relative to the frame.
Like GPS for the brain.
Exactly like that. In the operating room, the surgeon uses these coordinates to plan a trajectory. They drill a very small hole, maybe just the size of a quarter, in the skull at a precise entry point. Then, with the aid of the stereotactic frame, or sometimes frameless navigation systems, a hollow needle or cannula is precisely inserted through this small opening, carefully passing through the brain tissue along the calculated path directly into the center of the clot. A large syringe attached to the needle is then used to gently suction out the liquefied blood clot material. Sometimes clot-dissolving medication might be injected first to help break it down before aspiration. This targeted approach minimizes disruption to surrounding healthy brain tissue, which is absolutely vital for recovery, especially with deep-seated clots.
That's fascinating how technology allows for such precision, even deep within the brain, minimizing collateral damage. You mentioned aneurysms as a potential cause of ICH. Let's delve into those specifically now. What exactly is a cerebral aneurysm, and why are they considered so dangerous?
Right. A cerebral aneurysm, which is also sometimes called an intracranial or intracerebral aneurysm, is essentially a weak or thin spot on a blood vessel wall in the brain that balloons or bulges outwards and fills with blood.
It's like a little blister on the artery.
That's a great analogy. Imagine a weak point in the inner tube of a tire that starts to bulge under pressure. This bulging aneurysm can, just by its presence and size, start to pressurize a nearby cranial nerve or the surrounding brain tissue, potentially leading to symptoms even before it ruptures. Okay, but the most critical risk, the reason they are so feared, is that they may burst or rupture. When that happens, blood spills out under high pressure into the surrounding space or tissue. This is the hemorrhage. Specifically, often a subarachnoid hemorrhage if it's on the surface, or an intracerebral hemorrhage if it bursts into the brain tissue. And that rupture event is frequently catastrophic and life-threatening.
So rupture is the big danger. Do they always rupture?
No, not always. It's important to note that some small aneurysms may be found incidentally on a scan for something else, never bleed or cause any problems throughout a person's life. They remain silent.
Where do they usually form?
While they can technically occur anywhere in the brain's arterial network, most cerebral aneurysms are commonly found at the branching points of arteries, particularly in a loop of arteries called the circle of Willis, which runs between the underside of the brain and the base of the skull. These branching points are areas of high hemodynamic stress, making them more susceptible to weakening over time.
Okay, areas of high pressure and turbulence. Are there different kinds of aneurysms? Do they all look the same? Or do their shapes maybe tell us something about their risk or how to treat them?
That's a good question. Yes, aneurysms can be classified in several ways by their size, their location, their cause, and importantly, by their shape or morphology. Focusing on morphology, there are three main types to understand.
Okay.
First, we can differentiate between a true and false aneurysm. A true aneurysm involves all three layers of the artery wall, the intima, inner, media, middle, and adventitia, outer. The entire vessel wall weakens and balloons outwards, like a true bulge.
All layers stretched out.
Exactly. In contrast, a false aneurysm, which is also called a pseudoaneurysm, isn't a bulge of the wall itself. Instead, it's essentially a hole or tear in the artery wall where blood has leaked completely out of the vessel, but is then contained by the surrounding tissue or a clot, forming a pulsating sac next to the vessel, like a contained leak rather than a true ballooning of the wall.
Ah, I see the difference. What are the other types?
Second, and by far the most common type, is a saccular aneurysm. These are often widely known as Berry aneurysms because of their appearance.
Air aneurysm, okay.
It's a rounded or pouch-like sac of blood that is attached by a distinct neck or stem to the side of an artery, or, more commonly, right at a branching point where an artery divides. It looks very much like a berry hanging from a stem. These account for the vast majority of ruptured aneurysms.
Okay, the classic image.
Yes. Third, we have a fusiform aneurysm. Unlike the saccular type, which is an outpouching, a fusiform aneurysm is formed by a widening or dilatation along a segment of the artery involving all walls. It gives the vessel a more spindle-like or tubular, elongated bulge, rather than a distinct sac. These are less common than saccular aneurysms.
Interesting shapes, so saccular and fusiform.
Those are the main morphological types, yes. And these differences in shape are important for understanding the risk of rupture and definitely for planning the best treatment approach, whether it's surgery or an endovascular technique.
It's interesting how their shapes differ. And how do those differences, or just the presence of an aneurysm, manifest in symptoms? You mentioned the critical risk of rupture. Are the symptoms of a ruptured aneurysm quite distinct from one that hasn't ruptured yet? Because I imagine that distinction is absolutely critical for getting help immediately.
Absolutely critical. Yes, the symptoms differ significantly depending on whether an aneurysm has ruptured or not. And recognizing the signs of rupture is paramount for immediate action.
Okay, so what might you feel if it hasn't ruptured?
If an aneurysm has not ruptured, but is perhaps large enough to press on surrounding structures, the symptoms can be more subtle and might include things like persistent fatigue, maybe a loss of perception, problems with balance or coordination, speech difficulties, or blurred or double vision, sometimes localized headaches.
So neurological signs from pressure.
Exactly. These are often caused by the bulging aneurysm gently pressing on nearby cranial nerves or specific areas of brain tissue, or perhaps disrupting normal blood flow dynamics in a minor way. These symptoms might prompt someone to get a scan where the unruptured aneurysm is then found.
Okay. Now the critical one. What happens if it does rupture?
If an aneurysm has ruptured, the symptoms are typically sudden, extremely severe, and immediately alarming, demanding emergency medical attention without any delay.
Okay.
The absolute hallmark symptom is a sudden, excruciating, severe headache. It's often described by patients who survive as the worst headache of one's life, completely unlike any headache they've ever experienced before. Thunderclap headache is another term used.
Worst headache ever. Got it. What else?
This is usually accompanied by other signs of sudden neurological crisis, maybe a sudden loss of vision or double vision, severe neck pain and choline or stiffness, due to the blood irritating the meninges, the coverings of the brain, intense pain experienced above and or behind the eyes, nausea and vomiting, sensitivity to light, photophobia, confusion, lethargy, or even a sudden loss of consciousness or seizure. These severe symptoms are due to the blood suddenly spilling out under arterial pressure into the surrounding brain tissue or the subarachnoid space, causing intense irritation, a rapid rise in intracranial pressure, and direct damage to brain cells. It's a true neurological emergency.
Undeniably urgent. Given that critical nature of a rupture, how quickly and accurately can these aneurysms be diagnosed, especially when time is so absolutely of the essence?
Rapid and accurate diagnosis is paramount. You're absolutely right. Several diagnostic methods are used, and speed is key in the context of a suspected rupture.
What's usually first?
The computed tomography, CT scan of the head, without contrast, is almost always the first diagnostic test ordered in the emergency room for someone presenting with that worst headache of life.
Why CT first?
Because it's non-invasive, extremely fast, takes only minutes, painless, and widely available. And it's excellent for quickly diagnosing the presence of subarachnoid hemorrhage, the bleeding that occurs when most aneurysms rupture. Fresh blood shows up very clearly on a CT scan.
Okay, so it confirms the bleed quickly. Does it show the aneurysm itself?
A non-contrast CT primarily shows the blood. It might show a very large aneurysm, but often not the smaller ones. To visualize the aneurysm itself, a CT angiography, CTA, is often performed next. This involves injecting contrast dye into a vein and taking rapid CT scans as the dye flows through the brain arteries. The computer then reconstructs 3D images of the blood vessels, which can clearly show the location, size, and shape of the aneurysm that likely ruptured.
Okay, so CTA pinpoints the source. Are there other ways?
Yes. If the initial CT scan is negative for blood, but the suspicion for a rupture is still very high based on symptoms, sometimes a small bleed doesn't show up, a lumbar puncture or spinal tap might be done to check the cerebrospinal fluid for blood or blood breakdown products.
Ah, looking for blood in the spinal fluid.
Exactly. Another key imaging test, often considered the gold standard for detailed visualization of brain aneurysms, is conventional angiography, also called digital subtraction angiography, or DSA.
The invasive one.
Yes, this is the invasive dye test we mentioned before. A catheter is inserted, usually in the groin, threaded up to the brain arteries, and contrast dye is injected directly while rapid X-ray images are taken. This provides a very detailed dynamic map of the arteries and veins, showing the aneurysm's precise location, size, shape, and its relationship to surrounding vessels, which is crucial for planning treatment like coiling or clipping.
Okay. And what about MRI?
Magnetic resonance imaging, MRI, and magnetic resonance angiography, MRA, can also be used. MRI uses powerful magnetic fields and radio waves to produce very detailed images of the brain tissue and blood vessels without radiation. MRA specifically focuses on the vessels. MRA can show the size and shape of an unruptured aneurysm very well and can detect bleeding. However, MRI typically takes longer than CT and may be less practical in an acute emergency setting when speed is paramount, though it's excellent for follow-up or screening.
It's amazing how these different imaging technologies give us such a clear, detailed view into these incredibly intricate and dangerous conditions inside the head.
They really are indispensable tools.
Now, let's explore a truly fascinating and, well, somewhat counterintuitive neuroprotective strategy, therapeutic hypothermia, the idea of cooling the brain for protection after an injury. It almost sounds like something out of science fiction.
It does, doesn't it?
Mm-hmm.
It seems counterintuitive, perhaps.
Mm-hmm.
But it's very real, and the science behind it is compelling. What's fascinating here is how a relatively simple physical parameter, temperature, can have such profound neuroprotective effects at the cellular level.
Okay.
Therapeutic hypothermia, which is now more broadly known perhaps as targeted temperature management, or TTM, is considered a foundational neuroprotective strategy. Its core mechanism is surprisingly straightforward, in principle at least.
How does it work?
By carefully inducing and maintaining a lower body temperature, typically just a few degrees below normal, it significantly decreases the brain's metabolic rate. This helps to restore the critical balance between the supply and demand of oxygen and energy substrates in the injured brain.
So slowing everything down.
Exactly. Think of it like putting the brain into a kind of protective, temporary hibernation or sleep mode at the cellular level, reducing its energy needs during a vulnerable period.
Okay, and what does that actually do for the brain cells?
At a cellular level, cooling the brain provides a multitude of specific benefits that collectively help prevent further damage after an acute injury, like stroke or cardiac arrest or trauma. It leads to a reduction in excitotoxicity.
Excitotoxicity.
Yes, after an injury, brain cells can become overexcited, releasing excessive amounts of neurotransmitters like glutamate, which can actually kill neighboring cells. Cooling dampens this damaging cascade. Imagine your brain cells like tiny light bulbs flashing way too intensely after injury, basically burning themselves out. Cooling is like dimming those lights, giving them a chance to rest and recover.
Okay, less self-destruction. What else?
It also decreases the production of free radicals, which are highly reactive molecules generated during injury that cause oxidative stress and damage cell membranes and DNA. It reduces inflammation within the brain tissue, which is another major secondary injury mechanism. It helps preserve ATP, the cell's main energy currency, preventing energy failure. And importantly, it helps to avoid intracellular calcium overload, which is a key trigger for apoptosis, or programmed cell death that can occur hours to days after the initial brain injury.
So it's hitting multiple damaging pathways at once.
Precisely. It essentially slows down that whole cascade of harmful secondary processes that unfold after the primary insult, giving the brain a better chance to survive and recover.
So it's essentially slowing down these damaging processes to give the brain a fighting chance. Where has this strategy actually become standard practice, and where is its usefulness particularly noted in specific types of acute brain injuries like stroke or traumatic injury?
Right. Mild therapeutic hypothermia, typically targeting a core body temperature around 33 degrees C to 36 degrees C, which is about 91.4 degrees Arity to 96.8 degrees Arity, depending on the protocol.
Cooler than normal, but not freezing.
Exactly. It has become a standard of care, strongly recommended by guidelines in specific situations, most notably in post-resuscitative care following out-of-hospital cardiac arrest in adults specifically. After someone's heart stops due to certain rhythms, they are resuscitated but remain unconscious. Cooling has been shown to improve neurological outcomes in these patients.
Okay, after cardiac arrest, where else?
It's also standard care in cases of perinatal asphyxia in newborns. That's when a baby has suffered from significant oxygen deprivation around the time of birth. Cooling the infant can reduce the risk of death and major neurodevelopmental disability.
Wow, protecting baby brains too. What about stroke or TBI?
Beyond these established indications, its usefulness is increasingly recognized and actively researched in other specific neurological injuries. For ischemic injury, such as acute ischemic stroke caused by a clot, and global ischemia after cardiac arrest. Stroke, as we know, is a primary cause of long-term disability and mortality. Death and functional impairment rates are high, partly due to the fact that only a small percentage of patients get timely thrombolysis treatment, those clot-busting drugs.
Right.
Compelling animal studies have consistently demonstrated the benefits of therapeutic hypothermia started early during experimental brain ischemia, suggesting it can protect brain tissue when blood flow is compromised by clot. Human trials in stroke have had more mixed results so far, often related to timing and method, but research is ongoing.
Okay, promising but still being worked out for stroke. What about bleeding injuries?
For hemorrhagic injury, particularly subarachnoid hemorrhage, SAH, that's the bleeding around the brain, often from a ruptured aneurysm, therapeutic hypothermia offers a potential advantage, although it's not yet standard care. One issue after SAH is that patients often develop fever or hyperthermia.
Fever. Why?
It's thought to be related to the blood irritating the brain's temperature regulation centers. Hyperthermia can disturb neurological observation, making it harder to assess the patient's condition, and fever itself is known to worsen outcomes after brain injury. SAH patients in particular have a high rate of hyperthermia, maybe up to 65% during the first 7 days, especially if they have blood inside the ventricles.
So cooling could help manage the fever and protect the brain.
That's the rationale. Cooling can help manage this fever and potentially provide direct neuroprotection by reducing the brain's metabolic demands during this critical period. Again, large trials are ongoing to define its role here.
And finally, traumatic brain injury, TBI.
Yes, for traumatic brain injury, TBI, which is a primary cause of death and disability, especially in young adults under 45, therapeutic hypothermia is highly relevant and has been extensively studied.
Why TBI specifically?
Because the cell damage in TBI results not just from the initial impact, the primary trauma, but also significantly from a whole cascade of secondary injury mechanisms that unfold in the hours and days afterward, worsening the initial insult.
Ah, that's secondary damage again.
Exactly. These secondary mechanisms include things like cerebral ischemia, reduced blood flow, and hypoxia, lack of oxygen, widespread inflammation, excitotoxicity, metabolic dysfunction, oxidative stress, seizures, and brain edema or swelling. Ischemia in particular is a major determinant of the patient's outcome after TBI.
So cooling could target those secondary hits.
That's the hope. By reducing metabolic demand, inflammation, excitotoxicity, etc., therapeutic hypothermia aims to mitigate this secondary damage. However, large clinical trials in TBI have yielded conflicting results, and its routine use is still debated and not universally recommended, often depending on the specific type of TBI and available resources. It's important to remember that implementing therapeutic hypothermia, especially for acute brain injury, is not simple. It requires intensive critical care monitoring and management,
Right.
increasing the complexity and resource needs for patient care, especially after events like cardiac arrest or severe TBI. It's a carefully controlled, intensive intervention, not just applying ice packs.
Okay, from the incredibly delicate, contained world of the brain, let's shift our gaze down to the spine. This is the body's crucial support structure, the central highway for our nervous system, and also for so many people, a very common source of chronic discomfort. Let's start with chronic lower back pain. This is something so many people experience or know someone who does. What exactly defines it as chronic, and how is it categorized by medical professionals beyond just, my back hurts?
Chronic low back pain is indeed an incredibly widespread problem, affecting the muscles, bones, joints, and nerves of the back. Its classification hinges critically on duration. That's the key differentiator.
Okay.
Pain that persists for more than 3 months, so longer than the typical healing time for an acute injury, or, more specifically, pain that is persistent or fluctuating but lasts longer than 12 weeks, is categorized as chronic.
3 months or 12 weeks. Got it.
It's important to distinguish this from acute back pain, which most people experience at some point, maybe lifting something heavy, and it usually resolves relatively quickly on its own or with simple measures. Chronic pain, however, is often progressive, and frustratingly, for both patients and doctors, its exact underlying cause can sometimes be difficult to pinpoint definitively.
Right. So how do doctors try to sort it out?
When a patient presents with chronic low back pain, a thorough physical examination and a detailed medical history are essential to try and place them into one of several broad categories. This helps guide further investigation and treatment.
What are those categories?
They might include nonspecific low back pain, which is actually the most common category, meaning there's no clear underlying structural pathology like a fracture or herniated disc identified as the definite cause. Then there's pain associated with radiculopathy.
Radiculopathy.
That means nerve root compression, often causing pain that radiates down the leg like sciatica, or pain associated with spinal stenosis, which is a narrowing of the spinal canal itself, often causing pain or numbness in the legs with walking.
Oh, okay.
Another category is pain that is referred from a non-spinal source, meaning the pain is felt in the back, but the problem actually originates elsewhere, like the kidneys or pancreas. And finally, there's pain associated with another specific spinal cause, such as a vertebral fracture, a tumor, an infection, or inflammatory arthritis like ankylosing spondylitis.
So trying to narrow down the origin.
Exactly. This initial categorization is really important because it guides further diagnostic tests and ultimately the most appropriate treatment strategies. The how and where of the pain often dictates the what of the solution.
Beyond the physical discomfort itself, does chronic low back pain impact other aspects of a person's life? Because it just seems like something that persistent would affect more than just your back.
Oh, absolutely. The impact of chronic low back pain extends far, far beyond just the physical discomfort itself. It's strongly associated with significant sleep problems.
Sleep. Makes sense.
Patients often report needing a greater amount of time to fall asleep, experiencing frequent awakenings or disturbances during sleep, having a shorter overall duration of sleep, and generally feeling much less satisfied with the quality of their sleep.
And that must make the pain worse, right?
It absolutely can.
Eh,
It often creates a vicious cycle. Pain disrupts sleep, and poor sleep lowers pain thresholds and makes it harder to cope during the day.
Yeah. What else?
Furthermore, a substantial majority of individuals suffering from chronic low back pain also exhibit significant symptoms of depression or anxiety.
Really? A majority?
Yes, the rates are quite high. Living with persistent pain, functional limitations, and the impact on work and social life takes a profound psychological toll. Chronic pain isn't just a physical sensation. It truly affects a person's overall well-being, their mood, their energy, their ability to engage with life, not just their physical comfort level.
That's a really critical point about the holistic impact, sleep, mood, everything. Given how varied the potential causes and symptoms can be, what's the diagnostic journey actually like for chronic lower back pain? It sounds like there must be a wide array of methods to try and pinpoint the specific issue.
There is indeed, and the comprehensive array of diagnostic methods available is vital for trying to pinpoint the specific pain generator, though, as we said, it's not always possible to find a single definitive cause.
Okay, so what's typically done?
We often start with basic X-ray imaging, including conventional X-rays of the lumbar spine. These are fast, non-invasive, and painless, and they can help diagnose the cause and site of pain if it's related to obvious structural changes in the bones, like fractures, arthritis, instability, or severe disc space narrowing.
But they don't show everything, right?
Correct. It's crucial to understand that conventional X-rays do not show injured muscles, ligaments, or bulging discs directly. They're primarily for looking at bone alignment and degeneration.
Okay, so what's next if X-rays are normal or unclear?
For more specific insights, particularly into disc problems, sometimes a procedure called discography is considered, although its use is somewhat controversial.
Discography.
It involves carefully injecting a special contrast dye directly into a spinal disc suspected of causing pain, usually under X-ray guidance. The patient is awake and reports if the injection reproduces their typical pain. The dye then outlines any tears or damaged areas within the disc on subsequent X-rays or CT scans.
So it's provocative, trying to replicate the pain.
Exactly. It's often suggested for patients who are strongly considering lumbar fusion surgery, or those whose pain hasn't responded to extensive conventional treatments, and the exact disc source remains unclear. But it's invasive and carries risks.
Right. What about less invasive imaging?
Computerized tomography, CT scans are another option. These are also fast, non-invasive, and painless. CT is particularly good for looking at bone detail, so it's useful when things like a subtle fracture, spinal stenosis, narrowing of the bony canal, or significant bony spurs are suspected. CT scans pass X-rays through the body, and a computer processes them into detailed two-dimensional cross-sectional images or slices of the internal structures of the back. Better than X-ray for some things. Yes, better bone detail and cross-sectional view. But for looking at the soft tissues, the discs, nerves, ligaments, magnetic resonance imaging, MRI, is generally the preferred and most valuable tool.
MRI is the gold standard for discs and nerves.
Largely, yes. MRI uses powerful magnetic fields and radio waves, not X-rays, to produce incredibly detailed images of the lumbar region. It allows doctors to evaluate bone degeneration and injury or disease in soft tissues, including the intervertebral discs, the spinal cord, the nerve roots, muscles, ligaments, and blood vessels. MRI creates either two-dimensional or three-dimensional slices of the scanned tissue, making it excellent for visualizing things like disc herniations, nerve compressions, spinal stenosis, tumors, or infection.
So MRI gives the most comprehensive picture.
Often, yes, particularly for the structures most commonly implicated in chronic low back pain.
Are there other tests besides imaging?
Yes, sometimes electrodiagnostic procedures or EP tests like electromyography, EMG, and nerve conduction studies, NCS, are used. These tests assess how well the nerves and muscles are functioning. EMG involves inserting small needles into muscles to record their electrical activity, while NCS uses electrodes placed on the skin to stimulate nerves and record the speed and strength of the signal transmissions. These can help confirm if a nerve root is being significantly compressed or damaged, correlating imaging findings with functional deficits.
Testing the wiring, basically.
A good way to put it, yes. In specific situations, other tests might be used. A bone scan can help diagnose and monitor infection, hidden fractures, or certain bone disorders. It involves injecting a small amount of radioactive tracer material, which tends to accumulate in areas of abnormal bone activity. A scanner then generates images to identify these hotspots.
Okay.
Thermography uses infrared sensing devices to measure small temperature changes across the skin surface. The idea is that nerve root compression might alter blood flow and thus skin temperature in a specific pattern, but its reliability and specificity are debated.
Right.
And finally, ultrasound imaging, or sonography, uses high-frequency sound waves for real-time internal images. While not typically used for diagnosing the primary cause of most chronic low back pain like disc herniation, it can be useful for visualizing tears in superficial ligaments, muscles, tendons, or other soft tissue masses in the back.
Wow, that's an impressive diagnostic toolkit. A lot of options to try and get to the bottom of it.
It is. Though again, sometimes even with all these tools, a single, clear, smoking gun cause isn't found, leading to that diagnosis of nonspecific chronic low back pain.
Right. So once a cause is identified, or even if it's nonspecific, what are the various treatment avenues for managing chronic low back pain? Is surgery always the eventual outcome or the main goal?
Definitely not. In fact, quite the opposite. Treatment for chronic low back pain is really multifaceted, aiming to manage the chronic nature of the condition, improve function, and importantly, avoid unnecessary invasive procedures whenever possible. We almost always start with non-pharmacological treatments.
Okay, what does that include?
Well, some patients find short-term relief and improved functioning through acupuncture. The evidence is somewhat mixed, but for some individuals it seems to help with pain modulation, perhaps through endorphin release or other mechanisms. It's often recommended by physicians as part of a broader approach.
Okay. What about exercise?
Exercise therapy is really a cornerstone of managing chronic low back pain. This focuses specifically on strengthening and stabilizing the core muscle groups, the muscles of the abdomen, back, and hips that support the spine. Numerous studies have shown that targeted exercise programs can produce small but significant improvements in both pain levels and functional ability. It's about providing better muscular support for the spine and improving movement patterns.
Makes sense, strengthen the support system.
Exactly. Interestingly, behavior therapy, particularly cognitive behavioral therapy or CBT, has also been shown to be quite effective, sometimes as effective as exercise therapy, in managing chronic low back pain.
How does talking therapy help back pain?
CBT helps patients develop coping skills, change negative thought patterns about their pain, manage fear of movement, kinesiophobia, address associated depression or anxiety, and learn pacing strategies. It helps them reframe their relationship with the pain and improve function despite it. Often, a multidisciplinary approach combining exercise, education, and psychological support is most effective.
Right, treating the whole person.
Precisely. Now, when it comes to surgery, it's really important to emphasize that most patients with chronic back pain do not actually benefit from it.
That seems counterintuitive to some people.
It can be. But the evidence suggests surgery is generally best reserved for specific situations. It's typically considered only for patients who have clearly identifiable structural problems, like severe stenosis or instability, that correlate well with their symptoms, who have experienced significant functional disabilities and have unremitting pain, especially if it has lasted longer than, say, 6 to 12 months, despite a good trial of multiple non-surgical treatments.
So it's not a first-line or even second-line option usually.
Generally not for non-specific chronic pain, no. If surgery is considered, one option for specific disc problems is disc arthroplasty, where the original damaged intervertebral disc is removed and replaced with an artificial one designed to preserve motion.
Artificial disc replacement. Does it work?
It appears to be about as effective as traditional lumbar fusion surgery for short-term pain relief and function in carefully selected patients. However, critically, there's currently no strong evidence of long-term benefit compared to fusion, and long-term complications are still being studied.
Okay, short-term relief maybe. What else?
Another procedure, though less common now, is intradiscal electrothermal therapy, or IDEAT. This involves inserting a catheter into the damaged disc and applying heat. The idea is to cause collagen contraction within the disc wall for structural support and perhaps ablate nearby pain-sensing nerves. Studies have shown it provides maybe modest pain relief for some, but generally little improvement in function.
Sounds less promising. What about injections?
Epidural steroid injections are commonly used and can provide significant temporary relief, particularly for patients with radicular symptoms. That's the pain radiating down the leg along a nerve pathway, like sciatica, usually caused by a herniated disc or stenosis pressing on a nerve root.
Steroids to reduce inflammation around the nerve.
Exactly. The injection delivers potent anti-inflammatory medication directly to the site of nerve irritation. These injections typically provide small to moderate improvements in pain and function for maybe a few weeks, up to 3 months after administration. They can be useful to break a cycle of pain and allow participation in physical therapy.
Okay, temporary relief for radiating pain. Do they work for general back pain?
Generally, no. There's no good evidence to support their use in patients with chronic low back pain without radicular symptoms. And they are generally less effective in individuals with very severe spinal stenosis or those with extensive stenotic lesions affecting multiple levels in the lumbar spine. So it's really a targeted tool for specific types of nerve-related leg pain originating from the back.
That's a very clear breakdown of the diagnostic and treatment paths for chronic lower back pain, emphasizing conservative care first. Now let's shift our focus just a bit higher up the spine, specifically to chronic neck pain. This is another very common complaint involving the cervical spine. How does the examination of the neck differ, if at all, from the lower back? And what are its common causes and symptoms?
Right. Chronic neck pain is indeed another frequent issue. The neuroskeletal muscular examination performed for neck pain is similar in principle to the lower back exam, but obviously focused specifically on the cervical region and the structures it influences, like the arms.
Okay.
It typically begins with inspection, looking for any obvious deformities, swelling, or abnormal head posture and palpation, carefully feeling the muscles, joints, and bony structures of the neck for tenderness or trigger points. A cursory examination of the cranial nerves might be done quickly to screen for any neurological deficits originating higher up.
Checking nerve function from the head down.
Yes. Then the examiner will carefully determine the active and passive range of motion, ROM, of the neck flexion, extension, rotation, side bending, and often the shoulders and arms as well, looking for limitations or pain provocation. A detailed sensory evaluation is performed, usually testing light touch and pinprick sensation in the neck, shoulders, and down the arms in specific patterns, dermatomes, to check for nerve root irritation. Manual muscle testing assesses the strength of key muscle groups in the neck, shoulders, and arms, myotomes. And reflexes like the biceps, triceps, and brachioradialis reflexes in the arms are elicited using a reflex hammer. Sometimes specific provocative tests are done to try and reproduce neck or arm pain.
So a very thorough, hands-on assessment.
Yes, using tools like the reflex hammer and sometimes a safety pin for that sharp, dull pinprick testing, which is quite sensitive for detecting nerve pathway problems.
Okay. And what are the usual culprits when neck pain becomes chronic?
Well, similar to the back, muscle and ligament strains in the neck, maybe from sleeping awkwardly or a minor whiplash, usually heal within 6 to 10 weeks. Pain that lasts longer than 3 months is typically due to deeper, more structural problems within the cervical spine itself.
Like the discs or joints?
Exactly. The most common sources are often injury or degeneration, involving the intervertebral discs or the small facet joints at the back of the vertebrae, or sometimes both. Facet joint pain is, in fact, thought to be the most common cause of chronic neck pain after an accident, particularly whiplash injuries.
Facet joints. Where are they again?
They are small joints located on the right and left side at the back of each vertebral level, guiding and limiting neck movement. Pain from these joints is usually felt to the right or left of the center back of the neck, and it can occur either alone or alongside disc-related pain.
Okay. And disc injury.
Disc injury can also certainly cause chronic neck pain. The cervical discs act as cushions and allow limit neck motion. Their tough outer wall, called the annulus fibrosus, can be torn by a sudden forceful movement like whiplash. This tear itself can be painful, or can allow the inner jelly-like material, nucleus pulposus, to bulge or herniate outwards, potentially pressing on nerves and leading to persistent pain, numbness, or weakness.
So similar mechanisms to the lower back, just higher up.
Very similar underlying pathologies, yes.
And what are the broader symptoms of chronic neck pain? Does it also tend to affect things like sleep or mental state, similar to what you described for lower back pain, especially since the neck connects so directly to the head?
Yes, absolutely. Chronic neck pain can manifest with a wide range of symptoms that often impact daily life significantly, frequently extending beyond just the immediate neck area itself.
Okay, like what?
Well, beyond the localized neck discomfort, stiffness, or aching, common associated symptoms include headaches, specifically a type called cervicogenic headaches, which are headaches that actually originate from an injury or dysfunction in structures of the upper cervical spine, like an upper cervical disc, a facet joint, or the joints between the skull and the top two vertebrae, C1 and C2.
Headaches coming from the neck. Makes sense.
It does. Arm pain is also very common. This can be due to direct nerve compression from something like a herniated disc in the neck pinching a nerve root, cervical radiculopathy, causing sharp, shooting pain, numbness, or weakness down the arm in a specific pattern. Or, perhaps more commonly, arm pain can be referred pain from other irritated neck tissues like muscles or ligaments, which tends to be more achy and diffuse.
Okay, nerve pain or referred pain.
Right. Pain felt between the shoulder blades is generally another type of referred pain originating from structures in the lower neck. Interestingly, low back pain is occasionally seen alongside chronic neck pain and is quite common after whiplash injuries, potentially due to simultaneous injury to structures in the lower back like discs, facet joints, or the sacroiliac joints. It really shows the interconnectedness of the entire spine.
The whole chain is affected.
It can be. Beyond the physical symptoms, chronic neck pain, much like chronic low back pain, can also lead to cognitive difficulties, like problems with concentration or memory. This is often attributed directly to the persistent pain itself consuming cognitive resources and acting as a constant distraction.
The pain interferes with thinking.
It really can. Patients may also experience increased irritability and depression, stemming from the frustration, limitations, and impact of living with chronic pain. And again, just like its lower counterpart, sleep disturbance is a frequent companion to chronic neck pain, disrupting sleep onset and maintenance and contributing to that negative cycle of pain and fatigue.
Same cycle.
Exactly. Other symptoms that can sometimes manifest include blurry vision, ringing in the ears, tinnitus, odd tingling sensations in the face or arms, and just pervasive fatigue. The impact is indeed broad, affecting physical function, sensory perception, cognition, and emotional well-being.
That's a really comprehensive picture of chronic neck pain and its wide-ranging effects. You know, as you were describing the diagnostic methods and the treatments just now, it sounded remarkably similar, almost identical in parts, to what you detailed earlier for chronic lower back pain. Is there really that much overlap, or are there important nuances unique to the cervical spine that we should be aware of?
You've picked up on a very important point. Yes, there is indeed a significant overlap in both the diagnostic methods used and the general treatment approaches considered for chronic lower back pain and chronic lower neck pain. The underlying principles of diagnosing and managing musculoskeletal pain, joint dysfunction, and nerve compression issues in the spine are quite similar, regardless of whether the problem is in the lumbar or cervical segment. The basic building blocks are the same.
So the toolbox is largely the same.
The toolbox is largely the same, yes. So, just to briefly recap without going into all the detail again, the diagnostic methods potentially used for chronic neck pain, are largely the same as those we discussed for the lower back.
Okay.
These include X-ray imaging, primarily showing bone structure and alignment, discography, though perhaps used less often in the neck, computerized tomography, CT scans, good for bone detail and stenosis, and crucially, magnetic resonance imaging, MRI scans, which are often the primary imaging modality for detailed soft tissue and nerve evaluation, especially looking for disc herniations or spinal cord compression in the neck.
MRI is key for the neck, too.
Very key, especially given the spinal cord runs through there. Other tests might include electrodiagnostic procedures, EMG and NCS, to assess nerve function in the arms, bone scans if infection or tumor is suspected, maybe thermography, less common, and ultrasound imaging for superficial soft tissues.
Okay, same diagnostic tools. What about treatments?
Similarly, the treatment options largely mirror those for chronic lower back pain, starting with conservative care.
Right.
These include non-pharmacological treatments like acupuncture for short-term relief for some, exercise therapy focused on neck and shoulder girdle strengthening, stabilization, and postural correction, and behavior therapy like CBT to help manage the pain experience and coping strategies.
Exercise and coping skills.
Yes, surgical interventions are again typically considered only for severe, unremitting pain when non-surgical options have failed, or if there are progressive neurological deficits like significant arm weakness or signs of spinal cord compression, myelopathy. Surgical options might include disc arthroplasty, artificial disc replacement, which is perhaps more commonly performed in the neck than the lower back currently, or fusion surgery. Intradiscal electrothermal therapy is generally not used in the neck.
Okay, and injections.
And yes, epidural steroid injections or selective nerve root blocks can be used in the neck, primarily for patients with radicular symptoms that characteristic pain, numbness, or tingling radiating down the arm due to nerve compression in the cervical spine. They provide temporary relief by reducing inflammation around the irritated nerve root.
So, very similar approaches overall. Where's the nuance then?
While the tools and general principles are the same, the nuance comes in interpreting the findings and planning treatment relative to the cervical spine's unique anatomy and critical function. The cervical spine is much more mobile than the lumbar spine. It supports the head, and crucially, the spinal cord runs through a relatively narrow canal right there.
Right, the spinal cord itself.
Exactly. So compression of the spinal cord, myelopathy, from things like a large disc herniation or severe stenosis in the neck can cause much more widespread and serious neurological problems, affecting not just the arms, but also the legs, balance, and even bowel bladder function. Therefore, the threshold for considering surgery might be lower if there are signs of cord compression. Also, the proximity to the brainstem and major blood vessels going to the brain adds complexity. So while the conditions and treatments are analogous, the stakes can feel higher in the neck due to the structures involved.
That makes perfect sense. Higher stakes due to the spinal cord being right there. It's logical that the spine, being this continuous structure, would share diagnostic and treatment philosophies between its different regions. Let's zoom out a bit further now and discuss the broader category of degenerative spine disease. This seems to be the underlying issue for much of this chronic pain we've been discussing. Whether it originates in the neck or the lower back, what exactly is it?
You're right. Degenerative spine disease, sometimes called spondylosis, is often the underlying process contributing to chronic back and neck pain, especially as people age. It's not really a single disease, but rather a general term describing a group of conditions that involve a loss of the normal structure and function within the spine due to age-related wear and tear.
So basically the spine wearing out over time.
That's the most common association, yes. Just like our other joints, like knees and hips, develop arthritis, the joints and discs of the spine undergo degenerative changes with age. However, it's not only aging. Other factors like genetics, obesity, smoking, occupational stresses like heavy lifting or prolonged vibration, or previous injuries can accelerate or contribute to the degenerative process. It can also be caused or complicated by things like infection, tumors, muscle strains, or inflammatory arthritis.
Okay. And what's happening structurally?
The critical aspect here is that this degeneration, the breakdown of discs, the overgrowth of bone, the thickening of ligaments, can lead to pressure on the spinal cord and the nerve roots that exit the spine at each level.
The pressure problem again.
Exactly. This pressure can result from several consequences of degeneration. Discs losing height and bulging or herniating, disc displacement. The development of bony spurs, osteophytes, around the discs and facet joints, the thickening of spinal ligaments, and ultimately spinal stenosis, which is a narrowing of the central spinal canal where the cord runs, or the smaller foraminal canals where the nerve roots exit. Cartilage breakdown at the facet joints, facet arthropathy, also contributes to pain and stiffness. Essentially, the protective and flexible elements of the spine start to deteriorate, and the spaces for the neural elements get smaller.
What symptoms would someone with degenerative spine disease typically experience, and how serious can they actually get if the degeneration progresses and starts compressing those nerves or the spinal cord?
The primary symptoms are typically pain, which can be sharp or chronic, localized to the back or neck, or radiating into the arms or legs, accompanied by stiffness, weakness, limited motion, and sometimes sensory loss like numbness or tingling in the affected areas.
Depends on where the degeneration is worst.
Precisely. The specific symptoms often depend directly on the location and severity of the structural problem within the spine, whether it's predominantly in the neck, cervical, mid-back, thoracic, less common, or lower back, lumbar region, and which specific nerves are being irritated or compressed.
Okay, what happens if it gets really advanced, especially with spinal cord compression?
If the spinal degeneration progresses to the point where it causes significant compression of the spinal cord itself, spinal stenosis leading to myelopathy, the symptoms can become much more serious. The weakness and limited motion can significantly increase. Patients might develop difficulty with fine motor skills in their hands, like buttoning shirts or handwriting, problems with balance and coordination leading to falls, and a general feeling of heaviness or clumsiness in the legs.
Wow, affecting the whole body then.
Yes. As the problem worsens, it can even lead to more severe neurological deficits, such as the loss of bladder and bowel control, incontinence or retention, and problems with sexual function. These are considered red flag symptoms indicating potentially serious cord compression that often requires urgent evaluation and treatment to prevent permanent damage.
Definitely serious signs to watch for. You mentioned disc issues and bony growth. Can you explain a bit more about the underlying causes of this degeneration at a more detailed level, specifically concerning what happens to the discs and bones over time?
Sure. The primary underlying process often starts with the degeneration of the intervertebral discs. Remember, these discs sit between the vertebral bones, acting as cushions and shock absorbers, allowing for flexibility. They're composed of a tough, fibrous outer ring, the annulus fibrosus, and a soft, jelly-like center, the nucleus pulposus, and they have a high water content when we're young.
Right, the shock absorbers.
With age, these discs naturally lose water content, becoming drier, thinner, and less resilient. They weaken. This loss of height reduces the space between the vertebrae. The discs can then flatten, bulge outwards beyond their normal boundaries, or the fibrous outer ring can develop tears or cracks, eventually leading to a herniation.
The slipped discs.
Exactly, that's the common term. Disc herniation is a frequent cause of acute pain associated with spinal degeneration. It occurs when the weakened outer fibrous portion, annulus tears, allowing the inner jelly-like nucleus material to push or extrude out. This extruded material can then put direct pressure on nearby spinal nerves or even the spinal cord itself, causing pain, numbness, or weakness along the path of that nerve.
Okay, so the disc itself fails. What about the bones?
The disc degeneration sets off a chain reaction. As the disc loses height and stability, the adjacent vertebrae experience abnormal stress and movement. The body tries to stabilize the segment by forming extra bone. These are the bony growths, or spurs, osteophytes, that develop along the edges of the vertebral bodies and around the facet joints.
The body's attempt to fuse the area.
Kind of, yes. But these bony growths can unfortunately narrow the spinal canal or the openings where the nerves exit, foramina, adding further pressure on the spinal cord or nerve roots. This contributes significantly to spinal stenosis.
Ah, so stenosis is the narrowing caused by both disc bulging and bony growths.
Primarily, yes, and also sometimes by thickening of the ligaments within the spinal canal. Spinal stenosis, the narrowing of the canal, is potentially more serious than just degenerative disc disease alone because it directly compresses the neural elements. As the canal tightens, the spinal cord and/or nerves become significantly compressed and irritated. This compression can cause both localized back or neck pain and that radiating pain, neurogenic claudication in the legs, or radiculopathy in the arms, depending on the location and severity of the pressure. It's a progressive wearing down process that can have increasingly serious consequences over time.
So it sounds like a complex interplay of disc failure, bony overgrowth, and ligament thickening, all potentially leading to nerve or cord compression. How do doctors definitively diagnose this progressive degeneration, especially when, as you said, symptoms can be so varied and sometimes don't match the scans perfectly?
That's a key challenge. The diagnostic process usually begins, as we discussed, with a thorough history and physical examination to characterize the symptoms and look for neurological signs. Then, Imaging is typically employed.
Starting with X-ray again.
Often, yes. A spinal X-ray is frequently the starting point. It's good for showing the overall alignment of the spine, detecting obvious fractures or instability, and revealing structural changes associated with degeneration, like loss of disc height, bony spurs, osteophytes, and arthritic changes in the facet joints. However, as we established, plain X-rays do not directly show the discs, the nerves, or the spinal cord.
Right, so MRI is needed for the details.
Yes. Magnetic resonance imaging, MRI scans, are generally considered the primary means of diagnosis for assessing the effects of degenerative spine disease on the neural structures. MRI provides those highly detailed images of the discs themselves, showing bulging, herniation, loss of water content, desiccation, and critically, it clearly shows the nerves, the spinal cord, the amount of space available in the spinal canal, stenosis, and exactly how these structures are being affected or compressed by the degenerative changes.
So MRI really visualizes the problem.
It visualizes the anatomy of the problem very well. Computed tomography, CT scans, may also be used, sometimes in conjunction with MRI. CT is particularly good at showing bony detail, so it can be excellent for visualizing bony spurs, facet joint arthritis, and the exact dimensions of the bony spinal canal in cases of stenosis. Sometimes a CT myelogram is done where a contrast dye is injected into the spinal fluid before the CT scan, which can provide very clear images of nerve compression, especially if MRI is not possible or unclear.
Okay. But you mentioned scans don't always match symptoms.
That's the important caveat, yes. Diagnosis of back and neck problems, even with advanced imaging like MRI, can sometimes be complicated by false positives. It's actually very common to see degenerative changes like bulging discs or mild stenosis on MRI scans of people who have absolutely no back or neck pain, especially as they get older. Wear and tear is normal.
So a bulging disc on MRI doesn't automatically mean it's the cause of pain.
Exactly. Conversely, there are instances where a patient has significant symptoms, but their scans show only mild changes that don't seem to fully explain the severity of their pain. This highlights the absolute importance of clinical correlation. The doctor must consider the patient's specific symptoms, their physical examination findings, their history, and then interpret the imaging results in that context, rather than relying solely on the scan report. Treating the patient, not just the picture.
That's a crucial distinction. Treat the patient, not the scan. Okay, so considering that complexity, what about the treatment for degenerative spine disease? Is surgery the main answer once degeneration is confirmed, or are there steps taken well before that point?
Definitely not always surgery. In fact, far from it. Treatment for degenerative spinal disorders is highly dependent on the severity of the condition, the specific symptoms it's causing, and how significantly it's impacting the patient's quality of life and function. And it's really important to emphasize that in the vast majority of cases, the problem is not severe enough to require invasive treatment like surgery.
So what's the first approach then?
The first line of treatment is almost always non-invasive, focusing on conservative measures to manage symptoms and improve function. This typically includes things like activity modification, avoiding activities that worsen pain, periods of relative rest for acute flare-ups, using heat or cold therapy, and importantly, oral pain medication. This might include over-the-counter options like acetaminophen or NSAIDs, like ibuprofen or naproxen, or sometimes prescription medications like muscle relaxants or nerve pain modulators like gabapentin or pregabalin if there's nerve involvement. Opioids are generally avoided for chronic pain due to risks.
Okay, managing the pain. What else?
Critically, physical therapy is a cornerstone of conservative management. A good physical therapy program will focus on exercises designed to strengthen the core muscles supporting the spine, improve flexibility and range of motion in the back and hips, correct posture, and teach proper body mechanics for daily activities. It's about empowering the body to support itself better and reducing strain on the degenerated structures. Education about the condition is also key.
Building strength and better movement.
Exactly. For many people, this combination of medication for flare-ups, ongoing exercise, and lifestyle adjustments is enough to manage the symptoms effectively long-term.
When does surgery enter the picture?
Surgery may eventually become necessary, or at least a consideration, if a patient's condition progresses significantly despite a good trial of comprehensive conservative management, usually for at least 3 to 6 months. The specific indications for surgery typically include patients experiencing chronic, severe pain that significantly impacts their daily life and function, evidence of progressive nerve deficits, meaning worsening numbness, weakness, or reflex changes due to persistent nerve compression. And as mentioned before, the development of those Red flag symptoms like loss of bladder or bowel control, or progressive leg weakness, Cauda-Equina syndrome, or severe myelopathy, which often require more urgent surgical intervention to decompress the nerves or spinal cord and prevent permanent neurological damage.
So reserved for severe progressive cases not responding to other treatments.
Generally, yes. The goal of surgery is usually decompression, removing the pressure from Derv's cord, and sometimes stabilization, fusion, if there's instability.
That sets the stage perfectly for discussing a critical modern advancement in spinal surgery. If surgery does become necessary for these degenerative conditions or things like herniated discs, are there less invasive ways to tackle these spinal problems now? Techniques that perhaps spare the body more than traditional open operations. Let's talk specifically about minimally invasive spine surgery, or MISSS.
Yes, this is a truly significant development in spine surgery over the last couple of decades, reflecting that ongoing drive across all surgical fields for greater precision, less tissue trauma, and faster patient recovery.
Okay.
Minimally invasive spine surgery, or MISSS, encompasses a variety of techniques and approaches that were specifically developed to treat common spine problems like herniated discs or spinal stenosis, with significantly less injury to the surrounding muscles and other normal structures compared to traditional open spine surgery.
How does it achieve that?
The core idea behind most MISS techniques is to use smaller incisions and specialized instruments, often including microscopes or endoscopes for visualization, to access and address the problem area in the spine without the need for extensive muscle stripping or retraction that characterizes traditional open approaches. It allows the surgeon to precisely target only the problem area, minimizing the collateral damage to the healthy tissues overlying and surrounding the spine.
Less disruption, basically.
Exactly. The potential benefits are reduced blood loss during surgery, less post-operative pain, shorter hospital stays, faster recovery times, and smaller scars compared to comparable open procedures.
So when is this type of minimally invasive surgery typically recommended? Is it suitable for every spinal issue that might need surgery?
That's an important clarification. MISS is usually recommended only when a definitive period of appropriate non-surgical treatment, like medications, injections, and consistent physical therapy, has not relieved the painful symptoms caused by a specific identifiable back or neck problem.
Same criteria as open surgery, then. Failure of conservative care.
Generally, yes. Furthermore, spine surgery, whether it's minimally invasive or open, is typically only considered if the doctor can confidently identify the exact source of the patient's pain on imaging, like MRI or CT, and correlate it strongly with their clinical symptoms. For example, a clearly herniated disc pressing on a nerve root that corresponds precisely to the patient's leg pain, or documented spinal stenosis causing neurogenic claudication.
Needs a clear target.
Absolutely. MISS is not usually appropriate for vague, non-specific back pain where a clear anatomical cause cannot be pinpointed. Its primary role is often in decompression, which means surgically relieving pressure put on spinal nerves or the spinal cord by removing the offending material, whether it's portions of bone, like in a laminectomy or foraminotomy, or fragments of a herniated disc, like in a microdiscectomy. Sometimes MISS techniques are also used for spinal fusion procedures.
So it's a precise tool for specific, identified problems after other treatments fail. Can you walk us through the procedure itself? How does it actually differ physically from traditional open surgery in terms of accessing the spine? What's the key innovation, maybe the instruments used, that makes it minimally invasive?
Certainly. Let's contrast it with the traditional approach. In traditional open spine surgery, say for a lumbar discectomy or laminectomy, the surgeon typically makes a relatively long incision down the middle of the back, often 5 to 6 inches or more. Then the thick layers of muscle, the paraspinal muscles that run alongside the spine, are literally dissected or stripped off the bone and pulled forcefully to the side using large metal retractors. This provides the surgeon with a wide, direct view of the spinal anatomy, the vertebrae, discs, nerves.
That's pretty traumatic for the muscles.
It is. And this extensive muscle dissection and retraction is thought to be a major contributor to postoperative pain and longer recovery times associated with traditional open surgery. Through this large opening, the surgeon can then use standard instruments to remove the diseased or damaged bone or intervertebral disc material.
Okay, that's the open way. How does MELIS do it differently?
In many common minimally invasive spine surgery techniques, the key difference lies in how the surgeon accesses the spine. Instead of that long incision and wide muscle stripping, the surgeon makes one or more much smaller incisions, perhaps only an inch or two long, sometimes even less, directly over the target level.
Smaller entry point.
Yes. And the crucial innovation is often the use of a device called a tubular retractor. This is a series of nesting tubes, or a single expandable tube that is carefully inserted through the muscle layers rather than cutting and stripping them.
Through the muscle.
The surgeon uses sequential dilators, progressively larger smooth rods, passed over a guide wire to gently spread the muscle fibers apart, creating a path down to the spinal column. The final working tube, the tubular retractor, is then slid over the last dilator, which is then removed. This leaves the tube in place, holding the muscle fibers open just enough to create a narrow, protected tunnel or corridor directly down to the small, specific problem area in the spine, like the herniated disc or the narrowed foramen.
Ah, like looking through a keyhole.
Exactly like that metaphor. The tubular retractor essentially creates a minimally disruptive portal to the surgical site. Through this narrow tunnel, the surgeon can then insert specialized instruments designed to work in tight spaces, often guided by a surgical microscope or an endoscope, a tiny camera, for magnified visualization. They can perform the necessary actions, removing bone spurs, shaving down a herniated disc, placing screws or cages for fusion, all within this contained corridor.
So the muscle is pushed aside, not cut away.
Precisely. Sometimes, depending on the procedure, more than one tubular retractor might be used through separate small incisions to access different angles or levels. At the end of the procedure, the tubular retractor is simply removed, and because the muscle fibers were gently dilated and spread rather than cut extensively, they can largely return to their original position.
Much less muscle damage.
That's the goal. This implies significantly reduced trauma to the surrounding muscles and soft tissues, which often translates into less post-operative pain, reduced need for pain medication, smaller scars, shorter hospital stays, and potentially a faster return to normal activities for the patient compared to traditional open surgery for the same condition. It's really been a game changer for many common spinal procedures. #TagChat.
So after covering all that, what does this all mean for us? We've taken a really deep dive today into the truly incredible breadth of neurosurgical conditions. We've gone from the delicate, intricate structures of the brain and its vital blood supply, all the way down to the crucial and often pain-prone support system of the spine. It's been quite an illuminating journey, hasn't it? Really showing us the cutting edge of medicine.
Indeed. What really stands out to me looking back at everything we've discussed is the remarkable, almost unbelievable precision of modern diagnostics.
Yep.
The imaging, the tests.
Yeah.
And coupled with that, the diverse and increasingly tailored and less invasive treatment approaches that are now available. Whether it's those 201 focus beams of a Gamma knife, offering surgery without an incision, or the growing promise of immunotherapies harnessing the body's own defenses against aggressive brain cancers, or the refined techniques of minimally invasive spine surgery minimizing tissue damage. These advancements are truly transforming patient outcomes.
Right.
They really underscore both the immense complexity and the vital importance of the brain and spine in sustaining not just life, but quality of life. The ingenuity involved is simply astounding.
It truly gives you those aha moments, doesn't it? Realizing just how far medical science has come, gaining this detailed knowledge, seeing the potential path from maybe a silent symptom like in carotid disease, all the way to a highly specialized, targeted treatment. It really highlights the immense progress, and it definitely makes you wonder about the possibilities that are just around the corner.
Absolutely. And thinking about those possibilities, maybe a final thought for our listeners to mull over. Given how rapidly these neurosurgical technologies and therapies are advancing, becoming even more sophisticated, more precise, more effective, what ethical considerations or perhaps accessibility challenges do you foresee emerging? How do we ensure that these incredible, potentially life-changing treatments are actually available equitably to all who might need them wherever they are? Something to think about.